So, welcome back if you've been to other seminars that we've put on. Today we're going to talk about shoulder, all things shoulder. I'm Loren. I'm a physical therapist here in Carson City, from Carson, raised in Carson, love Carson. We made this of all the seminars we've done, this is the one we've done the least, but it's actually the one that I think, like, as you build seminars, like, you get better at them. And this one, if you came to the squat seminar, holy moly, did we not get through the material. Like, that is a 2-hour seminar. It really is. This is, when we're talking about the squat, we're talking about all of the joints. We're talking about shoulders today. So there was 70 slides, I think, in the squat seminar. There's 40 today. So still a lot, but we're going to really dive into the shoulder. And we're going to spend a lot of time looking at your own limitations. So I'm Loren here. I'm a physical therapist. We own the Health Lab. It's a physical therapy primary care clinic. Our clinic is a little different. So we don't take any insurance other than Medicare. And we have a concierge medicine practice in the clinic. We also have physical therapy. We are a one-on-one, 1-hour visit with your physical therapist. So one of the disadvantages of our clinic is that we have to use the word physical therapy. And I say that because, unfortunately, the way that the medical system's gone, reimbursements have changed so drastically for physical therapy. Typically, if you go to a clinic, for them to keep the lights on, you're one of 5 patients being seen at the same time. And it's nothing against the therapist or the clinic. That's what they have to do to kind of keep everything running. You get 10 minutes with a physical therapist. If I was treating in that clinic, I would not be able to give good care. So we do one-on-one, 1 hour, and the way we can do that is by people paying for us directly. We do these seminars for free so that you don't have to come see us. Like, if you can work on your shoulder stuff and work on your limitations, you don't have to come see us. That's ultimately what we would love, for you to just get better. We don't care how. And so we've done these because we love for the community overall just to be better, be more knowledgeable, and go from there. As always, if you've been at my seminars in the past, I think it's really important for people to understand the anatomy and some myths that our culture and the medical systems perpetuate that actually really hurt us when it comes to shoulders and shoulder rehab or anything else. And so we're gonna spend a little bit of time. I've made this as short as possible. This is the stuff that I love. And so we could talk about this for 2 hours. I've tried to make it short so we can really dive into the self-assessment and self-treatment, okay? And as always, please cut me off, raise your hand, ask questions, disagree, and we can talk through it. I think those are as helpful as everything else. Okay, I think it's important to start with a comparison when we talk about the shoulder. If we talk about the shoulder compared to the hip, the shoulder is kind of like a golf ball sitting on a tee. That thing's gonna fall off super easy, right? I don't golf, but I would imagine that golf ball is not very stable on that tee, and it can fall off pretty easily. The hip is much more like a fist in a baseball glove, or a baseball in a glove. That thing's not gonna, there's a lot of bony stability in the hip. So here's an x-ray of a hip joint. So here's the femur, the leg bone, here's your pelvis. You've got this deep socket that the ball fits into. Furthermore, there is an actual ligament that comes off the center of that hip that attaches to the hip bone, the pelvis. And so when they're doing a total hip replacement and you are completely out and all of your muscles are relaxed and they've cut all the way down into that area, to dislocate the hip, it is still a task to get that hip to dislocate. It's quite a bit of work. Compared to the arm bone, so if you were to take that golf ball and tee and you were to turn it 30 degrees to the side, that's actually how your shoulder sits. So if we take away all of the 18 muscles that cross the shoulder joint from the body, the torso to the arm, if we take away all of those muscles, this arm bone will kind of slide down with gravity. So there is a sign called the sulcus sign. And in the clinic, if someone has a really, really bad anatomical tearing of their shoulder joint, the arm bone, even when you're awake and the muscles are alert, the arm bone will slide down and you'll get this little divot in the shoulder joint, in the arm, because the arm is pulling down and sucking in, and you're getting this divot, you're getting this sulcus of the deltoid because the arm bone is slipping down. Okay, so when we compare these two things, tons of bony support and congruency, not so much. And so it's really, really the health and the stability and the positioning of the shoulder is really dependent on the muscular system, which is a plus minus. Compared to the hip, I've got tons of freedom and motion of my shoulder, which is a beautiful thing. And we get to do a lot of things with our shoulders because of the lack of bony limitations that the hip has. It also requires that all of these muscles work together to give us stability and function. And that's where we get a lot of shoulder limitations, is because of the way it's designed. I always try to think about the shoulder as an orchestra. So you've got all of these members doing their individual things, and if they're working together, we have beautiful music. If the shoulder muscles are all working together, we get beautiful movement. But if the trombone player is doing whatever the heck he wants, it sounds like crap. It also moves like crap. And so it's really this coordination of all of the system working well together to get that system to move well, okay? When we look deeper into this, we have the ball, which is the shoulder side, and we have the rotator cuff. The rotator cuff is just 4 muscles. It's 4 muscles that are coming off the shoulder blade, and they're grabbing onto the arm bone. So the rotator cuff is just 4 muscles that we've deemed the rotator cuff. Their job is to suck the ball onto the tee. They pull the arm bone onto the shoulder blade. They also coordinate some of the mechanics of how the arm moves in order to keep it centered on the tee. So if this is the tee and this is the arm bone, I've got to keep my ball, my arm, centered in the tee. And the way that happens is as I reach up overhead, the ball slides down and rolls up at the same time. If it only rolls up, it hits and collides with tissue. So the rotator cuff helps to coordinate this slide down, roll up, keeping it centered in the tee. That's one of its main jobs, okay? We also have the shoulder blade moving and coordinating as well. So if the tee, which is my shoulder blade, which sits 30 degrees off center, if it stays there, at some point, even if it is a nice slide and roll, it's going to collide with my collarbone and other structures as I go overhead. So the shoulder blade really beautifully rotates up and around so that that tee starts to position higher in space so that we get up overhead. So now we've got 2 joints coordinating together in order to produce the movement. We've got more members of the orchestra that need to work together to get this, okay? Also, we need, we covered this quickly in the squat seminar, we need really good thoracic extension in order for my arm bone to get into the position as well. So we're now adding a 3rd component, which is tons of joints and segments and muscles, in order to get this. So the orchestra keeps just getting bigger, okay? And if I have this, and I just create a little bit of stiffness into this, I've just lost motion, okay? So when we talk about the shoulder joint, yes, there are 18 muscles that cross the shoulder joint and they all have to work together. I also have all of the muscles of the shoulder blade and coordination of the movement of the shoulder blade that has to work together. I also have to have good thoracic extension to get this. There's a lot of members of the band And so we've got to see if all of these members are working together. Sometimes people will come in and they go, I have shoulder pain, and they've got really bad stiffness in their thoracic spine. We're working thoracic spine, their shoulder normalizes, we've never touched their shoulder, right? And so these pieces all have to come together in order for us to be able to do this. It's a beautifully complicated system that if we function and move well, it's going to work really well. Questions on any of that? See, I'm trying to go fast. In that, my profession and the medical profession and our cultures created some myths that hurt us when we need to rehab our shoulder. So let's go through 3 myths real quick. My profession really created this myth. There's the myth that your shoulder blades need to be even in order to have good function. So sometimes, even in school, we did this, it was one day in school, and it was called Naked Lab. You had to come in, and you had to be in your underwear, and you were with all of your classmates, and we did these assessments of where everyone's posture and situations and their shoulder blades and where everything was. And then we would take notes on, well, that person's shoulder was a little higher than that one, and this one was a little differently rotated, and so there was probably issues with this person's shoulder because of the shoulder blade position. What we see is when we treat someone's shoulder, their shoulder blade position rarely ever changes, even though they get normal function. That even when we try to treat the shoulder blade, it rarely ever changes, even though we make their shoulder blade better. And because of dominance, left versus right, so I'm, in a sense, if you're right-handed dominant, that shoulder blade has more muscle on it, it's got more weight to it, it should naturally sit a little lower. Symmetry in the body is really rare, and we've created pathology out of shoulder blade positioning that rarely is ever true. And so what can happen is like you might go to someone, or you might look in the mirror and be like, oh my gosh, my shoulder blade's different. Okay, I'm gonna really work to keep my shoulder blades even, which might be producing more fear and actually probably isn't helping anything. So where your shoulder blades sit, just let them sit. Sometimes when you have shoulder blade pain, you might do this to get overhead, and so you might have a little elevated shoulder. As we treat the shoulder and it feels better, this is naturally going to go back to its normal thing because it doesn't have to compensate anymore around the pain. So if we don't even treat it, it's going to normalize. So in our clinic, 1, we don't change it. 1, when we try to change it, it doesn't help. And 2, when we make it better, it goes back to normal. So don't even look at it. Don't even try to treat it because it's a waste of time. Okay? So if we aren't looking at it, you shouldn't be looking at it. Number 2, maybe all of the myths came from my profession. I remember in school, there was a professor, she was great. She would always whenever we talked about shoulder pain, she always brought up one example. She treated a bodybuilder who had these huge deltoids, and he had shoulder pain, and his deltoid was causing his shoulder pain because it was so strong, it was overpowering the rotator cuff muscles, it was pulling the arm bone up, and it was smashing the rotator cuff into the collarbone because the deltoid was just too strong. At the same time, we know the biggest predictor of shoulder health is how big your deltoid is. So the bigger my deltoid, the longer, the healthier, the longevity of my shoulder is going to be. So those two things are kind of conflicting. So sometimes what you'll hear in culture and in the medical world is, oh, your deltoid's too big. You got to let it atrophy a little bit and your shoulder's going to be healthier. It's like, it's a wild misbelief because we've had a theory, my profession created a theory, the deltoid was overpowering the rotator cuff. Well, that's not true. It doesn't. They work together. And if we can make the rotator cuff work well, it doesn't matter how big the deltoid is. And the deltoid, again, is the biggest predictor of shoulder health. We're going to show you ways to make your deltoid bigger today, and I want you to get big deltoids. If you have a fear because you've been told your deltoid will make your shoulder worse, you're not going to want to make your deltoids bigger. Don't worry about your deltoid. Just make it bigger, okay? All right. The last one. My shoulder hurts, I must need an MRI, right? And if you've been to any of my other seminars, this is always one. MRIs are supposed to be tools to navigate surgical intervention. They're not supposed to be diagnostic things. So I can show you hundreds of studies talking about there's not a great relationship between anatomical damage we see on MRIs and function or pain at all. So a study just came out. They were over 45 years old. There was 265 patients in the study. All of them had shoulder pain. Both shoulders had equal damage to their rotator cuff, anatomy, tears, partial tears, bursitis, acromial dysfunction, AC joint arthritis. Both shoulders had them, and yet only one shoulder hurt. 78% of high school baseball players have rotator cuff tears. None of them have pain in those studies. When we look at the natural progression of the anatomy over time, everyone's rotator cuff is tearing without symptoms. We should be very cautious to use the image as the diagnostic tool. So a female called me last night. She went to another physical therapist. That session unfortunately hurt her back. She said, I can send you the MRI because it's telling us what's going on. We don't need the MRI as a diagnostic tool. We use function and the clinical assessment as the diagnostic tool. And if someone has functional limitations that indicate maybe their anatomy is causing the dysfunction, we should use the MRI to correlate with those limitations that say, yeah, now they need surgical intervention. Whenever we do an MRI to diagnose function or pain, the surgical outcomes actually aren't that great. The moment we use the clinical assessment to diagnose anatomy damage and then use the MRI to show that that damage is there, the surgical outcomes are so good. And so everyone's body over time is naturally becoming deranged or anatomically torn, right? And yet that doesn't predict pain or dysfunction. Here's the study I talked about. This is another study that we've done these studies multiple times. 2019, 123 people had shoulder pain. We did an MRI of both shoulders. Both shoulders had 98% of the same damage. So our rotator cuff tendinitis, partial thickness tear, full thickness tear, bursitis, the collarbone arthritis, and labral tears. 98% of both shoulders had the same damage, and yet only one shoulder hurt. Anatomy damage happens naturally over time. It doesn't actually predict pain or dysfunction. It's the clinical assessment that actually predicts it. And the other thing to talk about, again, we could talk about this forever, the moment we talk about belief systems and perspective are the biggest predictors of success. So if you have a belief system that my anatomy is causing the problem and you come see me, I'm not making your rotator cuff look any better, you're far less likely to get better with my care. So when we have a whole group of people with low back pain and none of them have the clinical signs that they need surgery, half the group gets an MRI, the other group doesn't get the MRI, they both go to physical therapy. The group that got the MRI is 6 times more likely to have injections in their spine. They're 5 times more likely to have surgery, and they're 4 times more likely to have an increased level of pain over the next month. The MRI is a great tool, but when we use it in the wrong way, it actually hurts patients. And so when you have shoulder pain, and everyone's like, oh, well, would you get an MRI? Did you see what's going on? We should resist that unless we have the clinical findings, because it can hurt us. All right, when we think about, that's all, look at it. If you've been here before, you should be proud of me. I just cut that really short. When we think about any questions on any of the myths, any of the anatomy stuff, we literally rip through it. Reasonable? Okay.
Linebacker shoulders are wonderful. That's the way you should think about it.
Linebacker shoulders are wonderful. I was like, I don't know anything about linebackers. Yeah, it's strong. The repeatable theme is muscle mass is the insulation to health, wellness, and longevity, not for only our joints, but for us in general. We should have as much fat-free muscle mass as possible. When we think about the shoulder and any other joint, but specifically the shoulder, we always try to put people into 1 to 3 buckets. You either have a stiff shoulder that we need to gain motion in. You either have a very mobile shoulder that we don't need to get motion in, but once we get the motion in the shoulder, you got a mobile shoulder. At the end of the day, both stiff and mobile shoulders need to get strength. All roads lead to load, okay? So whether you're stiff now or you're mobile now, you got to get stronger. Because, like we just said, muscle mass is the biggest predictor of longevity of the joint, regardless of what the joint looks like from an anatomy perspective. I'm going to show you how to test if you're stiff. I'm going to show you how to get strong. If you're not stiff, you're probably mobile. You just need to get strong. This bucket's kind of funny because this just instantly drops you into this bucket. Okay? All right. Mobility. See, like we're like 20 minutes in, we're already starting some stuff. All right, so these are two of the things I'm going to have you test. Now, in this test, everyone's ability is going to be a little different. What you should assess in yourself is, one, can I get there? So what we're going to do on the first one, these are complicated movements. It's 2 movements in one. You're doing internal rotation and abduction together. And so all you're going to try to do is bring your hands up your back as high as you can. The second part of this, once you get there, is you're going to let your elbows come as far forward as you can, okay? Now, if that feels like tight, but it's symmetrically tight, if it feels like a little bit of like maybe pinchy in the front of my shoulders, but it feels equally pinchy, that's probably fine. That's okay. We're putting the shoulder in its end range of motion. If I have this, like that's all I got, right, on this side, that's a limitation that we want to try to treat, right? If I've got this, that's a limitation we want to treat. If I've got this and this, but man, my left shoulder really feels different than my right, that's something we want to treat. We do want symmetry in this movement, even though we have a dominant hand. So what we'll do is just take a moment, look to the person to your right or your left, grab a partner, stand up, put your hands as high up your back as possible, bring your elbows as far as possible, and just look at your partner and can they get their elbows equally forward? Can they get their hands equally high? Be your partner. I'll be your partner. How's that feel?
It pinches.
Equally?
Yeah, because I've had frozen shoulder.
Oh, you have? Yeah, okay. And then can you get your elbows forward?
That's it.
Yeah, but it's
Equal.
equal. Good. Yeah, perfect. Yeah, and then from there, just elbows. Can you go elbows? Yes, you see that difference? Yes, and does this feel worse? Or does it feel the same?
All of it feels tight.
Feels tight. Okay.
It looks like it's tight.
Yeah, and it feels tight here.
Yeah.
Yeah, so on this side, it'd be worth working. I'll show you how to work it.
Oh, right on.
Yeah, yep. You guys good? Any questions on that? Can I show you your shoulders? Yeah. Okay, good. So let's come back together. We'll show one example. What's your name?
Monica.
Monica's going to show us just a little limitation. It doesn't represent who she is as a person. Okay, face the mirrors. Hands behind your back.
Okay.
Elbows forward.
Are you sure? Okay. Oh.
And so, you're looking. No, okay, good. So, not bad. Not bad. Monica's gonna turn this way. Keep going.
Suck it in.
Do you see the difference on her elbow? Right? Now she's got symptoms on both sides, like that's an extreme position. But this little elbow here, this little chicken wing, this is something not predictive, but would be worth working on. Okay? Good. So that's just subtle little difference.
Yeah.
As long as it's symmetrical. Now, if you're like, we should work that.
I can't do the hand turn, whatever that, pointing up.
Don't worry about the hands. Just high on the hands, high on the elbows. Yep. And she's just got this little limitation. Okay?
I like he says little.
Yeah, it really is subtle. It is subtle. Yeah. Okay, good. Thank you, Monica. Everybody, Monica. Okay, so then the next one, and I'm going to show you how to treat that. We will get to that and how to treat it. And again, you could just Google, I have a limitation of this, and you could find 1,000 strategies to treat this. The treatment's less important than treating the right thing, right? So you don't need me if you know what's the limitation. Now you can just Google, I have an internal abduction limitation. How do I treat it? Write it down. On the opposite way, this is external rotation of the shoulder, and it's adduction of the shoulder. I'm going to try to get my hands here, not only here, but I'm going to try to point my elbows behind me. Okay? I also want to see, like, do I have this difference left to right? This won't be as pinchy, typically as pinchy as the first one, to get that pinchy. But you might find like, man, between my ribs feels really tight, or I might get like this little armpit tension on one side. Okay, so again, find your partner, do this, look for symmetries not only of motion, but of sensation. So go, can you get your hands as low as you can first, and then from there open, try to bring your elbows that way.
Yeah, I wish.
Do you feel it here?
Yes.
On both?
Yes.
Okay, good. Do you feel it here?
Yes.
Yeah. Okay, good. We'll work it.
Okay.
Yeah. Oh, you do? Oh, fun. Let's see. Let's see, Monica. Come on. No, this looks fine.
Really?
Are you? Yeah, that looks fine. Are you symmetric? Is like tight here?
Everything was always tight.
Tight here? Yeah. But it's symmetrically tight. I would say this is less important for you than this one for now. Yep. Yep. Let's use you again because it's a good example. It's a good example of like tight but not asymmetrical. Exactly.
Oh, I see her though.
Do you? Oh, good. Yeah, perfect. Yeah, we've termed her new doc. Okay, you guys good? All right, good. So we're gonna let Monica redeem herself. And this is a good example. Okay, remember if you came to the squat seminar, working on mobility that's not a problem is a waste of time. The time you spend on mobility that's not a limitation, you could just be working on strength. Don't only work mobility until it's not an issue, then stop working mobility. If you went to a physical therapist and they said, hey, work this, and then 5 years later, you're working the same thing, either one, you don't need to work it anymore, or two, you're doing the wrong thing to make it better, find something different to make the change, then stop doing it. You shouldn't have to work mobility until forever. It should go away. Okay, so do your motion. Okay. Yeah, face like like that. Like that. Okay, so Monica's like, oh, I gotta work this because it's so tight, and yet pretty dang symmetrical, and like her elbows are, but she's tight.
Yeah.
Right? She's strong and she's working the end of the motion. Like at some point, something's gonna bound down, but it's not asymmetrical and it's not a limitation in general. I would say if she's gonna work one or the other, she should definitely work the other thing first because there's an asymmetry there with some tension. The other thing is like, I can't tell you that's gonna produce any issues because she's getting overhead and it looks good. So in this one, tight, but not asymmetrical and not asymmetrically tight somewhere, right? Good? Okay, good. Good job, Monica. Okay. The beauty of these two tests that are a little complicated, and the reason we do them first is because it's kind of a cocktail hour. It's a 2-for-1 special. The thing you treat can instantly become the thing, or the thing you assess can instantly become the thing you treat. So if it's a limitation, you're going to put yourself into the limitation and work the limitation. Typically with this limitation, what happens is the shoulder blade and the arm bone compensate by falling forward to avoid. So if you watch, this is like, don't look at my ankle limitations, but I have some strength here. I've got tons of motion here, right? Without my arm bone, my shoulder blade falling forward. The way you can compensate around this is if you're really stiff, you can do that, and then it looks good, but this whole tissue is getting really, really compressed and gets pinchy. So a lot of times people will come to us. I've been a PT for 13 years. People will have pain here, and they get diagnosed with biceps tendonitis because it's here, right? And I've seen it once in my career, but I see this pain 5 times a week. This is the victim of this. So if I treat this, all of a sudden I can get here without it falling forward. This tissue doesn't get crushed because I'm doing this. Now all of a sudden this doesn't hurt. It's not a biceps tendonitis. It's a back of the shoulder stiffness that's crushing the front of the shoulder. So the reason the band, so if you just take a band, a really thick pull-up band, and you anchor it to the rig, the band's helping pull the arm bone backward so it's not crushing the front of the tissue, pissing it off. That's what the band's doing. Then from there, all you're going to do is work your limitation. If your limitation is this, you're going to work this. If your limitation is this, you're going to work this. So with the band pulling my arm bone back into a good position, I'm going to then just work the limitation, whatever it may be, so that the back of the shoulder starts to lengthen, elongate, relax, not forcing me to compensate with that forward positioning of my shoulder blade or arm bone. So instantly, you're going to just make the assessment, the treatment. You're going to do this with lots of volume. Right? So you're going to do this 5 times a day, and you're going to do 30 reps a day. Because we need to get a lot of reps into the limitation for the body to start to change over time. This isn't a fatigue thing, this is a mobility thing. The moment you go back to the assessment and it's symmetrical and kind of pain-free, stop doing this, just get your deltoid stronger. Okay? Questions on that? And this is where you have the slides at the end of this, and if you found this as a limitation and you want this video, I'll send it to you. Okay, because it's a funny movement. If the other one's your limitation, you're going to do the same thing. You're going to take the I don't know why I'm holding that. You're going to take the band to help pull the arm bone away from the point of pinch. Then you're going to work the limitation. Okay? When you're working mobility, it should never be sharp. It should be achy, sore, tight, awkward, or stiff. And you're going to work into that stiffness. And I always think of it as you're just brushing the limitation with thousands of reps to bring that limitation into normality so it's no longer a limitation. So that's where the 5 times a day, 30 reps each time, we're just brushing that thing. If you look at both of these treatments, we're never holding it in the limitation. We're never stretching it in the limitation. We're brushing it to the limitation. We're not pounding it through the limitation. What will happen is the brain, this is probably already irritated tissue. And if you're just banging into the irritation, your brain's going to go, ha, and it's going to cause a bunch of muscle tension to protect that irritation. Now you're not working the limitation. You're just working the brain's muscle stiffness, and you're not making any change. So this isn't about gritting through it and pushing and making it hurt. This is about brushing and making it change slowly over time. Okay? Questions on that? Again, I'll send you this. Okay, cool. First part, the most complicated things of the shoulder. What's funny is a lot of times people will come in, this hurts. And then we're treating this and like, why am I working behind my back and below my waistline to make this better? This is the key for this, okay? So sometimes it's not this that I gotta work, it's the lower stuff, okay? All right. Monica, when she did this, she felt tons of tension here, right? Which is fine. What can happen is the latissimus dorsi, it comes off the bottom of your pelvis, low back spine. It comes all the way up and attaches into the front of your shoulder. Huge muscle, and it can limit getting overhead. okay? So what we're gonna do next is we're gonna test to see if your lat is the limiting factor for you getting overhead. If you're doing this and you've got this like side to side, like only this side is limited when I did this test, or like this, and I got tons of tension here, it might not be the spine, it might be the lat. So we're gonna test to see if the lat's the limitation. In order to do that, a fun story about Dr. Sarah. So when Dr. Sarah started with me, she still had the typical PT mind of like, she swam her whole life, she swam competitively. Her shoulder motion was this, both sides. She had like no shoulder flexion. And she goes, well, yeah, I'm just a swimmer. That's how my shoulders will always be, right? And like, you're in a career that changes tissue and you don't want to change your own tissue or don't believe it will change? So if you can see where the wall's at, that's as far as she could get to the wall. She was like, we did it in inches. It was like 18 inches off the wall. Tons of lat limitation. Now she has none. She can get to the wall because she just changed it over time, right? But the test is this. You're all gonna do this. You're gonna sit against the wall. You're gonna cross your legs so your back's not in play. You're gonna grab the PVC pipe palms up. You're gonna go like shoulder width. You're gonna try to touch the wall, okay? Without bringing your low back off the wall or your head forward. Okay, so in this test, and don't bend your elbows. Okay, arms straight, here, everything against the wall. If you feel it between your shoulder blades, it's probably not a lat limitation, it's the thoracic spine. If you feel it in your armpits and you can't get the wall, it's probably your lat. Okay, good? Grab a partner and try. Oh.
I'm gonna have to buy one of those.
They do have an artificial shoulder.
Yeah.
Would you still do those with an artificial shoulder?
Yeah, you're probably not going to get normal though.
Okay.
Yeah.
I really don't need to do this. I already know I have limitations.
Yeah, and do you feel it in your lat? Fine,
Yep.
you do? Yeah,
Yeah.
so we'll just go to the treatment.
Yeah.
Yeah, perfect. Yeah, don't worry about it.
Yeah.
I don't think I can do this one.
Reasonable. You were like a couple weeks ago? 3 weeks ago?
Yeah.
Yeah, doing okay? Getting a little claustrophobic yet? Yeah. It's like the worst stage. Oh, yeah. Well, I only say that because it's going to get better. It's going to get better, I promise. Well, yeah. Let's see. Yeah, so elbow straight and grab the whole PVC. Yeah, so the moment you get that, you fall off that far. So that will go away. The treatment for this is going to be good. It's lat for her. It's your lat. You're feeling it here? Mostly? Yeah. Okay. Okay, you guys ready? You guys almost there? Don't do this treatment. It's a waste of your time. Beautiful. We'll start coming back together.
So now I have no excuses for my golf season.
Was it bad or good? Good. Okay, good. All right, so we'll come back together. Perfect. Okay, so as we do this test, a lot of things, the first two tests we did, there can be a lot of things causing the limitation. So we're going to do a lot of mobility. We're now testing, in a sense, a muscle, so we're going to blame the muscle until proven otherwise. Whenever we have a tight muscle, we should think one of two things. Either the muscle is tight because the brain is trying to protect the system, so the brain is involuntarily clenching the muscle to protect it, or the muscle's weak. So whenever we have a weak muscle, we always think that whenever it gets stronger, we always think the muscle gets diameter bigger, right? And it does. It also gets length longer. So in the reverse, when a muscle gets weak, it gets diameter smaller and length shorter. If I stretch a muscle, I'm going to make the tendon longer and the muscle shorter, which makes it weaker. That test is no longer a limitation, but I just gave the lat a disadvantage by making it shorter and weaker. If I want to make it longer and stronger and less restrictive, let's just make the thing stronger, right? Stronger muscles are longer muscles. Stop stretching tight muscles, make them stronger. All I'm doing here is I've got weights in my hand. I'm trying to keep my back flat and I'm bringing my arms up overhead, which is kind of like the test. We're putting it into length, okay? I'm not holding it here, I'm not stretching it. As I oscillate there back and forth, the first change you might get, when you do this once, you might be like, oh my gosh, I couldn't get my elbows to my eyes. By the end of the 30 reps, I got my elbows past my eyes. That change in 30 reps is all your brain relaxing the muscle. It's not doing anything else. After the first couple days of doing this, you're like, I'm always getting to my eyes, but it's not changing any further. Now, over the next couple months, as it starts to change, that's the muscle getting stronger and longer. Muscles take months to get stronger and longer. The brain takes minutes. So if you get in the beginning, that's the brain change. Once it doesn't change anymore, just be consistent until the test is no longer positive, and over time it's going to change. 1.5 years it took Dr. Sarah to get the test normal. Okay? It's consistent load making the muscles stronger and longer over time.
Is that on a daily?
For this, yeah. Yep, daily, yep.
And she works in a PT clinic, so.
Right.
The other option is if that one hurts your shoulders, if you're doing the first one and you're getting pinching in your shoulders, you can just go to the prayer stretch and you can start there, sinking your chest down towards the floor, doing lots of oscillations there, and then keep checking on the weight. Adding weight's always going to be a little better. The moment you can add weight and it's not pinching on your shoulders, do the first one, okay? Holding weight. Yep. So there's 2 options for treating that test. Again, Google lat treatment, lat length treatment, you'll find 1,000 options. The option that's the best option is the one that makes the change to the test, not the one I give you. But those 2 work really well for our clinic. Okay, thoracic extension. We did this in the squat seminar briefly, but we'll go over it again because it is important. So as you're sitting in your chair, you're going to come to the front of your chair. You're going to put your hands behind your back. You're going to support your jawline with your head so you're not moving your neck. You're going to try to point your elbows. So I'm at horizontal right now. I'm going to try to get my elbows at least to 45. Okay? If you can get to 45, that's not an issue for you. If you do this and you get a bunch of tension between your shoulder blades, then it's probably a factor for you that's worth treating. I would say yours is lat though, because that looks good. Your lat is more limiting. Yeah. So simple test. If you feel that between your shoulder blades, we should treat your thoracic spine. So if on this thing, if the last thing you did was kind of tight but not that bad, but then this one was worse, we should treat this first. Okay? So treat the lowest hanging fruit first. Simple test, simple treatment. So these balls are perfect shape to treat your lat. And whenever we can add a little bit of load, it's always kind of better that you're putting more load on the fulcrum. So if I just lay against the ball, that's my low ribs are touching the ball. Everything above this is upper thoracic. Okay, I can just support a weight behind my head, and then I can point my elbows as far back as possible, right? Working that motion. If it's stiff, you might just be like this. And over time, you'll just get that motion back. The moment you can do this test and you get to 45, stop doing this, get strong. Okay? All of these things we're doing, It's 5 times a day, 30 reps, brushing the limitation into normality over time. When the limitation is no longer a limitation, stop doing it. This is a great shape to really hit that thoracic spine. When you're sitting, you might have felt like a little bit of low back tension. I can compensate with this with low back, like, oh, I'm normal, but it's all low back. If you can't, you have to go thoracic spine, okay? All right. This is less of a limitation. Typically, it's not the lowest hanging fruit. If any of the tests prior to this one were limited, you should work those first. Thoracic rotation is also a very important thing for this. And so I'm going to show it to you. What you're going to do is you're just going to be here. You should be able to rotate 45. I'm pretty limited here. And so if you're limited but symmetrical, maybe less of a factor, but that rotation is a key. So I'm trying to keep my hand on the ground, trying to keep my pelvis level. I'm trying to point my elbows behind me, seeing that, okay? For sake of time, we're gonna just we'll go through that next. This is another cocktail hour. The test becomes the treatment. What she's doing here is taking a band and she's rotating it around the shoulder that's limited, okay? The band is helping her go into the rotation. It's pulling her into the limitation, right? So now she's just doing the assessment into a treatment. The band is the load, it's the kettlebell, and she's brushing the limitation hundreds and thousands of reps a day until it's no longer a limitation, okay? Cool? Awesome. Okay, this one's a key one that I want to go over. So we're breaking this one apart a little bit. This is typically a big limitation we see. So what you should have, unless you're a baseball player, you should have 90-90, 90-90. You should be able to get 180 degrees of arc of rotation. If you get here, but this happens, right? You've done the same compensation that this showed. The rotation is the limitation, okay? If you can't do this without this, or it looks like that, the back of the shoulder is the culprit here. Go ahead, let me see. Yeah, okay, will you come stand up? Come on. What's your name? Tamara. Tamara's got a good little example here. So Tamara, face this way. Do this side. So come up high, and then watch her arm. Her arm's gonna, both are doing it, so it'll be perfect. So if she shows, she's gonna drop her arm. I'm gonna put my hand right in the front of her. See how it dives forward? This is an issue here. This is the victim. This is the issue, okay? She can't get there, so I'm gonna stop you. Put your arm to the top. I'm gonna stop you when you start to compensate, right? Go slow, right? Right there. That's all she's got. From there forward, keep going now, she shoves her arm forward and she pinches this tissue. Okay, so really, every time she's doing something and lifting, which you would be surprised how often you get in this position in life, she's doing this tissue is going to get pissed. This is the victim. Okay? Thank you.
Okay.
To treat this, you're going to lay on your back. I'm going to then roll onto my shoulder blade. Let me show the picture. So I can't compensate. So if I do it flat, I can just shove my arm forward every time I do it. And now all of a sudden I have a client because their arm hurts. Okay? If I roll onto my shoulder blade, now I can't really compensate because my shoulder blade's smashed between the ground and my ribs. Now, if I have the limitation, I can treat the motion. My other hand helps me come up, so I'm not really working as much fatigability strength. I'm just working the limitation. I'm going to try to touch the edge of that tension and then back down. If I can touch the ground without compensation, this isn't an issue, right? But the moment I can't, now I'm doing 30 reps 5 times a day, brushing that limitation. As this is no longer a limitation, we can make this weight really heavy. I can't lift it with the arm. I can lift it with both. Now I can eccentrically lower it to build strength. So this mobility becomes a strength tool with time when the motion goes normal, okay? So that is how you want to do it. You want to just be thoughtful of smashing the shoulder blade into not being able to compensate so you can work the limitation, not the compensation. Okay, we're going to skip this one because I want to go to strength. Okay, so the only one we didn't cover is external rotation. Rarely is it actually a limitation, but if it is one, you'll see it. We did that in the other squat, but usually, so if I have a shoulder is the number one thing we see in our clinic. It goes shoulder, low back, hip. Let's say I see 5 shoulders in a week. 80% of them are going to be limitations to the back of the shoulder that's causing the front of the shoulder to hurt. So we treat the back of the shoulder. So we've tested stiffness, now get strong. If none of those tests were a limitation for you, like good job, because that's rare. You're not a stiffness limitation, you just need to get strong. So now everyone just needs to get strong. The moment the limitation is no longer there, you're in the strength. If you don't have any limitations, just keep getting stronger. This exercise is called the trio. It's on a metronome. So you might have seen this in a physical therapy clinic before, and people will rip through it, and it's not that hard. If you do it well, this exercise is going to smash your deltoids. So here's 60 beats a minute. 1. Okay, and then I'm going to come here. Thumb leads. 1, 2, 3. 1, 2, 3. 1, 2, 3. 1, 2, 3. That's one set, one rep. I'm going to do that 12 times.
Guess what we're going to be doing?
So it's 3 up, 3 down. If you got that, right? 60 beats per minute, 60 beats per minute. 3 seconds up, 3, 1, 2, 3. This is 5 pounds. If I don't have any shoulder issues, I have decent muscle mass in my deltoid. If I did 5 pounds, 3 reps, 3 sets, 12 reps, I would be on fire in my deltoid at the end of this, okay? This is a great one that people don't do well, that then they don't get the benefit of it. So slow down, make it work hard. You're gonna get some good deltoid strength out of this. An interesting thing about the shoulder and the rotator cuff is the hand and the shoulder are really connected. So it's rare that I'm going to use my shoulder without gripping something. And we know if I have my hand like this and I grip something but don't use my shoulder, my rotator cuff instantly contracts. Okay? So the stronger my rotator cuff, the stronger my grip strength. The stronger my grip strength, the stronger my rotator cuff. You can make this exercise significantly harder on your shoulder by just gripping this thing as hard as you can while you do it, okay? That simple thing will make your deltoid and your rotator cuff more fatigued and stronger. So if you're ever working on something and your shoulder kind of hurts, the first thing you should do is just grip the object harder while you're doing it, and your shoulder irritation might go away while you're doing the activity. Okay, first line of defense. This exercise, again, is a simple one that do you have a foam roller? I don't have a band. It's okay. Don't worry about it. You'll see this a lot. It's just the subtle keys. The bands around the wrists And when people do this, you want to make a Y. A lot of people go straight up. So there's no resistance on the band. If I do this with resistance, it makes the deltoid harder, work harder. Sarah's also pushing as hard as she can into the wall, not with her body, but with this shoulder blade pressure. So she's pressing into the foam as hard as she can. She's rolling out as hard as she can. This will smoke your shoulders if you do it well. So pressure, pressure, up and over, simple things that's going to help you build strength if you do it well. These are so typical PT-related exercises. If we just do them well, they're going to work a lot better. But at the end of the day, this and the last one aren't actually going to produce enough strength for you to carry a bag of dog food into the cart. The gap between what this can produce and what you need to do in your life is too great. And the biggest limitation of physical therapy in my profession is we tend to stop before we gain functional strength. We got to bridge that gap, which is why Kaya is so beautiful. What you're doing at Kaya to build strength is really bridging the gap. And so if we can start here, but not end here, that's a great place to start. If you're having trouble getting overhead, you can take a barbell, put it into the corner of a wall or a rig. You could put a tennis ball on the end of the barbell. Now she's doing presses, but it's more stable because it's on an anchored surface. She can load that bar up as heavy as she wants. She's not getting full flexion until she leans forward, so she can decide how high she wants to go with her shoulder overhead based on how it feels. She can get her shoulder really, really tired, more functional than the first two, but also adaptable to where you're at, and we can add as much load as we want onto that bar for strength. Okay? We talk about grip strength. I can flip this kettlebell upside down. Now I've got to grip it.
Turkish get up.
Thank you.
So she's doing a Turkish get up, right? We call these Turkish sit-ups because she's just stopping at the sit-up position. What's happening to her shoulder? She's doing this, but from a lower half requirement. She could do the same thing like this, right? The moment we get the kettlebell upside down, now I've got to grip it. Now the shoulder works harder. Now I'm getting more deltoid rotator cuff recruitment for the same exercise. This will make your shoulder much more fatigued just by adding the kettlebell upside down. Go light because grip strength's gonna go out of you before your shoulders do, but this is a good way to start working full shoulder flexion, deltoid strength, with the kettlebell being upside down. You could then progress it to pressing, right? Upside down kettlebell presses. And that is more recruitment than this simply because of my grip. If you have another misconception is these are dangerous for your shoulders. They're not. They're really good for your shoulders. What I'm trying to do is trying to pull the bar high and get what I'm trying to do is get my forearms horizontal. I don't want to do this, okay? It's fine, this is better. If you are having a barbell with weight and I'm pulling high, this is a great exercise to build the deltoid up, okay? Again, now I can load that bar as heavy as I want. So if the dog food's not the issue, it's a bale of hay, the gap is now filled because I'm just loading the barbell to wherever I want to be in my life, right? Okay. We in the medical system love to critique gym rats and barbell bodybuilders. Typically what happens is they will do something that makes no sense, and then all of a sudden the research correlates with what they're doing to make sense, and then we adopt it and we like to take credit for it. A bunch of my profession says that these are dangerous for the shoulder, right? Because we're treating people that have shoulder pain. When I do this, it hurts, so therefore it must be dangerous. If your shoulder's great and healthy, This is going to totally make your deltoid work really, really hard. The reason bodybuilders have huge deltoids is because they're doing stuff that's loading specific tissue that's making it bigger. Specifically, if we want a big deltoid, we should load the deltoid. That's going to load the deltoid in a way that's going to get it like unlike anything else. The deltoid has 12 heads to it, meaning there's 12 components of this deltoid. You know, when I say the deltoid, you guys know like this big upside down teardrop, right? There's 12 components to it. It has a 270-degree rotation around the shoulder. It is the armor of the shoulder. The reason she's got to do 3 motions and then hit it here is we get all of the heads of the deltoid and the 270 degrees when we do all 3 motions. If we're only doing this, we're only hitting here. If we only do this, we're really only hitting here. If we do this, we're getting that back side of the deltoid.
How does it, what's the difference between palms down and thumbs up?
You might get a little bit better recruitment of the deltoid here, but it could be a little more uncomfortable. So sometimes you'll get here and it might feel better.
Right.
And that's
Maybe that's true.
totally fine.
Okay.
Totally fine.
But same recruitment? Oh no, you say more recruitment.
More recruitment here because you can get a little bit of other stuff. All that's meaning is you're getting more muscles to work and they're going to get stronger too. What a wonderful thing, right? If I want to get pure deltoid, I'm going to do this if I can, pain-free, because I'll get specifically deltoid.
But you feel pain, it's fine to go.
100%. Yep. Good question. Those are ways to strengthen. That doesn't mean it's the only way. Most people who want to get stronger love to get fancy before they get specific. So, as an example, back in 2018, I was doing Ironmans and ultramarathons. I currently weigh 205. I weighed 155 at the time. I was super lean. I was hurt all the time, all these things. A buddy of mine said, if you want to make your back stop hurting, you should start lifting weights. After I told him he was stupid, I went to his house at 5 a.m. 3 days a week. We did 4 exercises for a year and a half. Only 4. We followed these principles. I gained 25 pounds of muscle in a year and a half, right? And I was young, and so muscle mass building is easier when you're younger. It's still doable at any age, it just might take longer. 4 exercises. A lot of people have to go in the gym, do 20 things, and they miss these components. They're wasting their time. If you're going to build a cake of strength, here's the 4 ingredients. You've got to be consistent. You've got to do it 3 to 4 days a week. You've got to go to near failure. This is one that most people miss. Whether you're doing lightweight or heavyweight, you've got to get within 3 reps of near failure. If you're not doing that, you're missing this piece of the ingredient. It takes a whole lot less time. If you go heavier to get to 3 reps of failure, now you're going to have more time in your day for other things. That's the benefit of going heavier. But you can get strength with low weight, high reps. You just got to do more to get near failure. You also have to be patient. So like we talked about, the first 8 weeks of any strength program, what you're mostly doing is changing the way the brain contracts the muscle. So if we take someone off the street, they join Kaya, they're lifting weights. In 8 weeks, they're going to lift more weight than when they started. That is almost no muscle mass improvement. It is the brain contracting the muscle better. So if you stop in 8 weeks, it's going to go away quickly because it's just brain. The longer you go and you build up muscle mass, that's harder to get to go away, but you got to be patient. The last one is 1 gram of protein per pound. Most people, so when we look at the guidelines by the CDC, it's 1 gram of protein per kilogram, okay? When you look at what they're trying to do in that encouragement is they're trying to reduce malnutrition, not thriving. So if you want to have non-malnutrition, 1 pound per kilogram of protein per day. If you want to build muscle mass, we need to get more protein than that. And so 1 gram per pound is incredibly hard to do. If you don't have any kidney dysfunction, you're going to be fine. So I weigh 205, I'm trying to get 150 to 185 grams of protein a day, right? And I'm still not hitting this, but it's a whole lot better than 1 gram per kilogram. So intake of protein. One of the things I'll highlight on this is just that the studies in the past used to say you can only absorb up to 25 grams of protein per meal. And when you buy a protein drink, it's usually 21 to 25 grams of protein in that thing. And that's the reason they did that is because of those studies. In those studies, what they did is they just took protein isolate, like protein powder, and they had people drink it. And they drank more and more and more, and they saw they were only absorbing about 25 grams. The problem with that study is, if it's purely protein, you can only absorb so much at a time. If I have a steak with potatoes and it's 50 grams and it digests slower and it takes longer, your body's gonna absorb way more than 25 grams. So what you're intaking has a lot to do with what you're absorbing. So if you're eating a protein-rich meal and then having a protein shake between it and then a protein-rich meal that's real food, that absorption is completely different than someone sitting in a lab and drinking protein drinks. So you can absorb more than 25 grams if you don't just double up on your shakes, try to focus on a protein-rich, normal, real food. The beauty is we have all this technology. If you've used any AI, so I use Gemini, like I'm trying to lose 15 pounds right now, okay? So all I'm doing is I go into Gemini, it's free, you turn on your camera, you show the thing that you're eating, and you say, can you total my macros and calories for the day if you care about calories? You put your hand next to your plate for reference, and it will tell you this meal, it will tell you what's in your food, and it says it's this many grams of protein, this many grams of carbs, this many grams of fat, and then you say, can you just total it for the day and then give me at the end of the week how I did? And it will do it all for you, okay? And it will track everything. So then all of a sudden when you have your breakfast and it says, you had 10 grams of protein, you're like, oh my gosh. If you take a 3/4 cup of Greek yogurt and you put a protein scoop in there and you put 100 grams of frozen berries and you mix it all up, it tastes pretty decent and it's about 45 grams of protein, right? You can change your protein intake really, really easy. That's a key piece. Next month, Dr. Sarah Nicole, different PT. Oh, I had a picture of her. She's coming to talk about osteoporosis, how to treat osteoporosis, the keys to osteoporosis, some myths about osteoporosis. She's our newest physical therapist. Sadly, her name's Sarah as well. But she'll be here. Sarah Nicole, she's incredibly smart. She used to be a personal trainer. She's wildly smart. And so she's going to be doing a seminar on osteoporosis. So come to that. And if you have any questions, I'm happy to hang out and answer questions. Feel free to text us. This is the QR code for the PDF, and I hope this was helpful. Thank you.